morning, everybody. Thank you for coming here today, and I hope you will enjoy this coming 2 days. I will start the talks today with talking about the treatment targets in IBD, where we're going from now, and maybe it's a bit of a heavy meal in the beginning of the morning. I try to make it useful for the non-gastroenterologist and for gastroenterologist. So to start, we'll talk about what is a treat to target, why treat to target in IBD, what's the current target. We'll talk later about histological remission, review the data, talk about incidental barrier, and then we'll summarize. So this is my disclosures. So what is treat to target? So we know the concept of treat to target is that we should have a target to treat the disease, and then we aim to reach that target by giving like therapies, switching therapies, doing some tests, imaging or blood tests to reach that target. This strategy is supposed to reach that target because we think this target is the important endpoint. And sometimes those targets should be personalized to some patients, not the whole population, so we need also sometimes personalized target. We know all this graph in IBD, that's the time to referral is important. We know there is a window from the inflammation to symptoms, and the earlier we diagnose those patients, the better and the less complication, and it's easier to reach that target. If we delay the diagnosis, then reaching the target is not quite easy. Treatment to target is not a new concept in IBD. It's always been there in medicine. We know, for example, in diabetes, the target is HbA1c less than 7, and we know we have data that if your HbA1c is a bit less than 7, you're less likely to develop macro and microvascular complications. In hypertension as well, like the target is BP less than 140/80. For non-hypertensives, for diabetic is 130/80, and those also been shown to reduce the risk of stroke and so on. Same for dyslipidemia. We have also targets that reduce, depends on the risk stratification and the risk of cardiovascularity. So the concept of treat to target is not new, and it's also we have this target in medicine, and also we have it in IBD. This is like a nice cohort, a Norwegian cohort study, symptom-based, and how our IBD patient have symptoms over the years. And this is like following a patient with Crohn's disease for 10 years, and you see patient for 20 years, and you can see like symptom-based, we can have like 4 categories of patients. The first category of patients who have severe flares first, and then they have slow, like mild flares. Around 43% of patients with Crohn's disease and 69% of UC. And then the second group of patients who have low, like initially small flares, and then they have a bad flare. Usually those are like not the common patient we see. And then the chronic continuous patient, with those patients who have like always have a flare, they never into a remission. And also this is a group patient. And the last group is the chronic intermittent, where they have flare up and then they go into remission and they flare up again. The most common ones are maybe 1 in 3 and 1 in 4, and 3 is sometimes, but 2 is not very common. So this also the figures that you all know about, like in Crohn's disease, we know that the diagnosing patients early prevents constipation and prevents damage. The later we diagnose the patient will have inflammation, fibrosis, then fistula is complication, abscesses will be difficult to treat. So treating those patients early and reaching targets early to delay complication. Maybe it's also in UC to some extent. The data in UC is not as robust that treating early will delay complication. We do have some data with decreasing risk of colectomies. However, the data is not as robust as in Crohn's disease. Also post-operatively, we know look at this nice figure that patient also, like when they have surgery for Crohn's disease, the inflammation maybe start like as soon as a week later, but they have histological disease, and then by the time those high-risk patients, they develop endoscopic recurrence within 1 year. So how was treatment goal? So like treatment goal, if you can see like later and like in 1970s, the earlier trials was started with a clinical response, was CDI reduction of more than 70, and then the CDI score more than 70s in the clinical response, and then the clinical remission was CDI score, like most trials, around less than 150 the goal was, and then moving to endoscopic remission, then we had endoscopic remission depending on the CCD score or CII score, and CCD score is less than 4 or less than 2, depending on the trial. So, but what is the next treatment targets? We know, like now, the coming trials, we'll talk about them, the recent trials. We like talking about histological remission, a patient-reported outcome, which is now it's an outcome mainly about abdominal pain and stool frequency, and endoscopic outcome. But the coming outcome likely is histological remission and imaging, MR enterography, and intestinal ultrasound may be coming targets. We're going like just to review the data. STRIDE 1 is like a recommendation who came up in like 2015, was by expert in the field, initiated by the International Organization of IBD, and there come like 12 recommendations. The composite endpoint in Crohn's disease was clinical and pro remission, which is a patient-reported outcome. The clinical remission was resolution of symptoms, and endoscopic remission was usually assessing called colonoscopy 6 to 9 months, ensuring the patient healed. But the clinical remission was not an endpoint, so the target is endoscopic remission. And you see kind of similar clinical remission, usually the absence of rectal bleeding and improving of diarrhea. Endoscopic remission also like mucosal healing, usually 6 to 12 months. And there is adjuvant measures, also the seroactive protein, fecal calprotectin. Usually these are not target, but this was useful to monitor inflammation. Histology was not considered a target back then. And then the 2020 STRIDE 2 and came with intermediate targets and long-term targets. The intermediate targets was defined decrease of more than 50% of the pro patient-reported outcome, abdominal pain and stool frequency. And then the intermediate, the long-term target was the definition of endoscopic healing, CCD score less than 3, that's for Crohn's disease, and absence of disability and improving quality of life. And you see kind of similar things, so pro and improvement of symptoms was the intermediate target. A normalization of the seroactive protein, fecal calprotectin is the intermediate target, and the long-term target is endoscopic healing and the absence of disability and normal quality of life. The question is now, are these targets good enough, and shouldn't we include histology? So the problem with these targets, they are good. Endoscopic, we know that endoscopic remission improves the outcome, delay complication, but there is still residual inflammation. And those residual inflammation is like we can only see by histology. However, for both Crohn's and UC, we don't have a standard scoring system to score histological remission first. There are several histological scores that have been developed, I'll talk about later, but mainly in the UC, more validated in UC than in Crohn's disease. So which score to use and what are these scores before talking about the next target? So the common histological remission scores, the Roberts Histopathology Index, the Nancy Index, the GBOS score, the simplified GBOS score, the Global Histology Activity scores, these are the common usually UC scores. And some studies report just by histological finding, we'll talk about that later, without a scoring system, just absence of erosion or ulceration. So what's the Roberts Histopathology Index? It's validated for UC. They use a score from 0 to 3 to grade each chronic inflammatory infiltrate, lamina propria neutrophils, neutrophil in the epithelium, and erosion or ulceration. The score ranges from 0 to 33, and there is like an equation to calculate this score. And depending on some studies call remission is less than 5, or less than 3 is remission, less than 5 is remission or mild activity. And then the next one is the Nancy Index, is developed, also validated to assess histological activity in UC. It's a graded inflammation, acute inflammatory infiltrate and chronic inflammatory infiltrate, and has a scale of 0 to 4. And you can see here, like if the patient has ulceration, you can go back and you can see the figures in the right, how can you score the patient, and usually if there is 0, this indicates significant absence of histological activity, and 4 indicates severely active disease. Then GWAS score, which is the commonly used one, but not recommended one. We'll talk about it. It ranges from 0 to 5.4, with higher indicate more severe disease, and usually it depends on the study you read. Histological activity is GWAS score more than 3.1, and GWAS histological with no activity is less than 3.1, and some study uses GWAS score less than 2 as a strict criteria for remission. So 3.1 or two, depends on the studies. Then a simplified JOBA score, which like a few, 5 or 6 years ago, added plasmacytosis, neutrophil and epithelial damage were kept in the simplified JOBA score as a marker of microscopic activity. Eosinophils in the lemma propria was also added. And this is a score from 0 to 4.4. How about the remission by histological findings? So in UC, like the histological remission usually will be called, and there is the absence of erosion, absence of fecal neutrophil infiltration, basal plasma, cytosis, or any inflammatory signs. In CD, unfortunately, the data is not robust. Some studies suggested that use mucosal normalization, quiescent disease with architectural changes without any neutrophil infiltrate are signs of histological remission in Crohn's. The next is how did randomized controlled trial reported histological remission. So we did a systematic review about this maybe up to January 2023. We included 3 RCTs in IBD with active comparator arm. Only recent RCTs reported histological remission. 10 were UC and 1 in Crohn's, and 21 RCTs reported endoscopic remission only. You can see here the Unify one reported remission, defined remission as a neutrophil less infiltrate less than 5%. If you can see, the Vaxity trial remission was defined as GWAS score less than 2 or IHS score less than 3. The visible one remission also GWAS less than 3, and histological minimal activity if GWAS less than 3.2. And the True North trial histological remission was divided GWAS less than 2. The selection trial for forgetinib, they didn't specify the score system, but they said the GWAS and score, and there is known or mild activity increase in chromic lymphocyte rate. This they called it as a remission. And moving to UAchieve also had GWAS score of less than 3.1, and then moving to the Hibiscus trial, it had NHI less than 1, and Laurel trial has an NHI less than 1. And lastly, Unity 1 and 2, the change in GHAS score, which is the change in the global histology activity score. It's also like you can find it in an app. It's a bit long histological scoring system. So the question is which one to use. So the only 2 recommended by ECHO in ulcerative colitis are the Roberts Histopathology Index and the Nancy Index. The JOBA score, however, is the most commonly used score outcome in biological and small molecules in UC. If you combine the RCTs and observational data, the JOBA score is the most commonly used, however, it's not the one that's recommended. For CD, the most of the histological scoring system and complex, to be honest, are not very validated. And that's mainly because of the transmural nature of CD. It's a patchy disease, and maybe the histology is not good enough to tell us about the healing. We need imaging, usually MR enterography, for example, or intestinal ultrasound. And they may not accurate in histology and in Crohn's may not accurately reflect the deepness of remission. So the question comes, does it impact the clinical outcome? So does histology impact clinical outcome? So STRIDE-2 and STRIDE with long-term targets, they target clinical and endoscopic remission. Transmural healing in Crohn's and histological healing were not considered formal target yet. However, they recommended to assess the measurement of depth of remission. However, there are several observational studies showed that achieving histological remission may improve clinical outcome and complication in ulcerative colitis. And there is like some of studies were showing positive and some shows negative. But however, the shared and long-term clinical benefits such as hospitalization, need for surgery are still not well established. So this is another one I'm showing you, does this histological remission improve long-term outcome, which is the most important clinical question. So this is the systematic review that we're presenting next month to the ECHO. So we did a meta-analysis of all the data, 31 studies, 30 observational, and 1 RCT. We defined short-term outcome, 6 to 12 months, patient on remission, long-term more than 12 months. The primary outcome was primary clinical relapse. Secondary outcome was hospitalization and surgery. So definition, we defined histological, by histological deficient, we'll talk about that later, like absence of erosion, ulceration, And GBA score, we use also GBA score less than 3.1, and we also use the strict GBA score less than 2. So risk of clinical relapse, as you can see, those, if you can see, here I can't, if you can see in you can see that, first the histological, the histological remission definition was absence of neutrophil epithelial infiltrate, erosion, crypt abscesses, basal plasmacytosis of preserved goblet cells. And then you can see that both short and long-term outcomes were both significant compared to active histology. So both patients who were in histological remission were less likely to have a clinical relapse, short-term and long-term compared to the active histology. And then how about if we use the GBA score, studies who use GBA score, if we use GBA score less than 3.1, the short-term our clinical relapse outcome was significant, the long-term was not significant. However, if you use a strict GBA score, then the significant long-term outcome was significant. As you can see here, the conversion table, the p-value were both significant. How about the secondary outcome? Risk of hospitalization, the short-term was not significant. There was not a lot of studies, but long-term was significant. So the patient with histological remission and long-term, they will have less likely risk of hospitalization. Need for surgery, also the long-term risk was lower than active histology. So to summarize these data, so relapse by histological feature or by using strict GBA score, long-term hospitalization and surgery, they both were significant in those in histological remission. How about in Crohn's disease? So for all Crohn's disease, there was, they used all patients were followed more than 12 months. However, there was no significant association between histological remission and outcome. But there is a lot of limitation to the Crohn's data because some studies used only ileal biopsies, some studies used both ileal and colonic biopsies. We know the transmural nature of Crohn's disease, so this may not be a good target, the biopsies. And they also, because of this, like small studies, and you can see the heterogeneity here is high, 93%, because of the small sample, and the data is not robust. So in Crohn's disease, we don't have a good data to support clinical histological remission. So the strengths of those, like all possible definition that used in the studies were used, showed important short and long-term follow-up period we defined. This is a clinically relevant question. There is a gap in knowledge about this. However, most of the studies are observational with high heterogeneity. We don't have a standard definition for all studies. And unfortunately, in Crohn's disease, transmural hearing was not investigated. So what does this study may tell us? So maybe this in UC, it's the histological remission represent a good target, but yet not routinely used in clinical practice. In histological remission in UC, patients with histological remission have better outcome in terms of clinical relapse, histolization, and surgery. However, this outcome is not robust in Crohn's disease due to the transmural nature of it. However, these data are mainly prospective data, so we need more prospective studies to confirm these findings. So any new target, so interestingly, like a few months ago, this came up. So this is an intestinal barrier target. This is a prospectively study comparing the predictive value of barrier healing with endoscopic and histological remission. The primary outcome of predicting long-term behavior in a large cohort of patients with Crohn's in clinical remission. So what did they use? They used the confocal laser endomicroscopy and high-resolution imaging technology that enables surface real-time endoscopy. It's enabled functional assessment of the integrity of the intestinal barrier. Some pilot studies have shown that barrier dysfunction in patients with IBD correlates to clinical disease behavior and long-term outcome. So their methodology was they use a patient with IBD for at least in 12 months presenting and were in clinical remission during January 2017 until December 2019. They use a CDI score of less than 150 or partial Mayo score of less than 2 with no individual score less than more than 1. And all patients were in biological therapy, and they did colonoscopy with CLE done was at baseline. And they injected the fluorescein injection at the TI, cecum, and rectosigmoid along with the histological sample, and leakage was assessed compared to the histology and endoscopic signs healing. And they followed the patient clinically every 8 weeks. So the outcome was major adverse outcome, and major adverse outcome was defined by disease relapse, IBD hospitalization,
Dr. Mohammed,
IBD
you have
surgery,
2 minutes left.
and decision for initiation or changing the dose. The time to event was used by Kaplan-Meier score. The mean follow-up was 25 months, and number of patients around 81 with UC and 100 with Crohn's disease. And if you can see that the data, like similar to what we showed before that, the Mayo endoscopic score, if you use number A versus active disease, there was significant difference. Mayo endoscopic score of 0 versus above 0 is also significantly different. And if they use histological remission of RHI less than 3 versus more than 3, or less than 3 more than 1, they all significantly different. What about the intact barrier? If you can see here nicely that if a patient who have intact colonic barrier versus less likely to have a major event versus those who have barrier dysfunction. So this study showed that barrier dysfunction is a risk of clinical relapse and surgery and hospitalization. Then we'll go about Crohn's disease. They showed that the patient with a less CCD less than 3 versus more than 3, if you can see in A and B, less likely to have outcome. However, histological remission was not statistically significant. And the last figure down there, they used modified Riley score, it's a 6 histological score, not really validated, and same to our data. And Crohn's disease, this is not still a good target. The problem with this study, the single center in Germany is a very specialized center. They do this kind of like dynamic or real life assessment of the function, not available everywhere, where different pathologists were involved and different endoscopic, so there was no central reading. So they conclude that this endoscopic barrier dysfunction may be a good target in the future. So what's the take-home message here? So treat the target is an important cost step in many chronic illnesses to avoid complication. In IBD, currently the treatment target is endoscopic remission and improving patient quality of life. These targets have been shown to reduce the slow progression of the disease and prevent complication. Histological remission and transmural healing and coming future target. Histological remission you need, maybe it's a reasonable target to improve outcome, yet we need more prospective data. Histological remission in Crohn's disease is not yet well established. We don't have a standard score, and transmural healing is what maybe need to be addressed, and maybe Dr. Heba will talk about that later. Barrier dysfunction maybe is a potential a new target in IBD. And however, the problem is in clinical practice, those targets is difficult to achieve. We have difficult time now achieving targets, especially in Crohn's with endoscopic remission. We know that's very difficult to reach endoscopic remission in Crohn's disease. So what if later we have histological remission? Are we able clinically to do this? How are we going to do that? Are we doing like more biologics? Are the new biologics are better than the older ones? Or we may need to combine biologics which are costly to reach histological remission. So this cost and strategy to reach target to remain to be just investigated and discussed later. Thank you.